Everybody, bienvenidos. Welcome to the webinar. I'm one of your hosts, Ryan Martin. Hopefully, if you saw the introduction, you got a little glimpse of who I am. If you don't know who I am, you'll get to know us over the course of the next hour. So today's webinar is going to be hand and wrist. So we're going to be throwing some polls out there. With our polls, we'll probably be giving some free giveaways, a couple things like that. So stay on point, because as we ask you questions, there might be some free swag and stuff that goes along with those. So be on top of that. This is Colin Rigney. Colin.
Yeah, welcome everybody. Thanks for spending this time with us tonight. Ryan's going to walk us through the checkpoints in the hand and the wrist. And my name is Colin Rigney. One of the founders of AMSKU, and Ryan and I have a singular mission to make MSK Ultrasound the gold standard of anybody who's treating patients with joint pain in anywhere you are in the outpatient setting. And so these webinars are our contribution to the community in just making this education more accessible. And it's really our pleasure to be able to work with you all and take you all through what we love to do. So you want to give them the instructions on how to best view the seminar?
Yeah. So what we found is that if you have picture-in-picture, a lot of the times the ultrasound is really small, or our faces are really small, or where our hand placement is really small. So what I recommend is, if you are to go to the little slide bar down at the bottom, there's going to be 3 dots. On the 3 dots, under those tiles is going to say layout. Under layout, you want to hit tiled. If you hit tiled, they're going to go side by side, so they're going to be equal in size. So if they're equal in size, you're going to be able to see both the ultrasound as it's going live, and you're also going to see how I'm doing the scan. So you're going to see the screen here. So we do have the machine right here, but you're not going to want to pay attention too much to that. You're going to see, and we have a model in here. We brought someone in to demonstrate hand. I'm sure he was in plenty of magazines for his hands. But what I recommend is go to that tiled view, and you'll see them side by side. One thing I want to recommend, or one thing I want to talk about is, and hopefully you guys can see this okay, this is tonight's agenda. Now I'm going to go over to Julius and ask, Julius, does this pop up on the screen? Yes. Yeah. He says yes. Our model says yes. So what we're going to be doing tonight is obviously hand and wrist. Within the hand and wrist, we're going to compartmentalize it. We're going to show you a couple of different ways that we scan. In most clinics, and this will be a poll question, is in most clinics, they see a lot of carpal tunnel or first dorsal compartment tenosynovitis. But we're going to be going over the carpal tunnel, how to locate it, some of the landmarks that you want to look for, and some easy ways to locate that median nerve. After that, I'm looking at doing the dorsal wrist compartments. There's 6 of those, and I want to go into those in detail, and I want to show you kind of like a little cheater way to get really good at those dorsal 6. From the dorsal 6, you can slide down. We're going to look at that scapholunate ligament and the scapholunate joint. From there, I was thinking about looking at the first CMC, because we get a lot of arthritic conditions that mimic itself as tenosynovitis over that first dorsal compartment. So it's good to understand that saddle joint and what it might appear as. Lastly, I want to look at the A1, A2 pulley system, and then I might come in and have the resident expert come in and do the UCL, also known as a Stenner's. Now, there's a couple of things that happen down at that Stenner's, or that skier's thumb. It's very imperative to do this correctly. There's an aponeurosis and a tendon that you need to know very well and very intimately. So I might have Colin come in and teach that one at the end. Anything you want to add, Colin?
No, I think just keep in mind as we're going through this protocol tonight that this isn't an all-comprehensive list of things. So we want to keep it essentially intermediate, but we want to keep it practical. And so Ryan's going to be covering, like you mentioned, a lot of the things you're going to be seeing most common in the clinic. What's going to apply to most people who are going to be using ultrasound. And so really that's the mission tonight. And I'm going to step aside. Ryan, we'll let you get going. So Julius, if you want to come in and step in, man. Ryan, I'll get you set up.
So do we have any jokes to start the night off?
No. None that I feel comfortable talking about in public.
Julius. Welcome to the world. This is Juliet. So we're going to be using Julius's hand. So go ahead and lay down here. And let's go to Zoom. And let's have your hand here. And we're going to make sure that everybody is able to see what's going on the screen. Share the ultrasound video. And I'll wait tight until Colin says, while we're waiting, Julius, what is the worst place to hide in a hospital?
I don't know.
ICU. All right. So that's dumb. That's my dad joke for the night.
Give us a thumbs up.
Yeah, give us a thumbs up if you like that. Colin, I will need some ultrasound gel.
Okay.
I do believe there should be some around here. So FYI, everybody, just be prepared when you're doing your ultrasounds. Ultrasound gel is pretty important. I do believe we have some in that box right here, Colin. So what I'm going to be going over first is carpal tunnel. So when going over the carpal tunnel, a couple of things you need to understand is patient position. So you could have a patient sitting with their arm on the table, and you could be side by side with them, or you can have them laying down just as Julius is here, and we could be looking for that carpal tunnel right through here. Now, we know the big structures that we care about in carpal tunnel syndrome is going to be the median nerve and entrapment over that retinaculum. What I recommend for everybody is getting used to locating that carpal or that median nerve about 4 to 5 centimeters from that carpal row. So from that crease in the wrist, you want to come up about 4 to 5 centimeters, a little bit, so you can see the extensor digiti, the flexor digiti flexor digiti profundus and superficialis. So without further ado, let's take a look at this. Julius, are you comfortable? I guess that's always important to ask, right? And we are live. Colin, is that coming up? Yes. All right. So as we go, what I want everybody to understand is, and I'll have a cursor here, is as we go through, you can see my probe is a couple centimeters or a couple inches from that dorsal, volar wrist crease. As I come up a couple centimeters here, what I'm looking for is, Julius, go ahead and wiggle your fingers. You can see the flexors here and here. So this is the superficialis. This is the profundus right through here. Thank you. And so what we have is right smack in the middle, this piece right in here is the median nerve. Now it's really easy to locate the median nerve at this level because one, it's nestled between the two muscles, which makes it hyperechoic. So it's easier to see. And what you want to look for is this bundle of grape or this honeycomb appearance right in here. So as you can see, my probe, what I'm going to do is I'm going to start slowly scanning distal. And you can see that nerve is going to start rising a little bit more superficial. So you can still see it right in this region here. And Colin, what is that big muscle that kind of hangs out at the bottom right there?
That's the pronator quadratus.
Yeah, so the pronator quadratus. So once you get past this level here, you're going to see another muscle come into play. And this is the pronator quadratus right through here. Rarely is it implicated at this level. Usually you see it in the pronator window closer to the elbow, but this is something that you do want to be mindful of. Because you know at the level of the pronator, that median nerve is going to start going from the center of the screen between the superficialis and between the profundus, and it's going to be rising up towards the retinacular space. So as you can see this nerve, I want everybody to follow closely right here. Hopefully you can see my arrow. And can I get a thumbs up on everybody if they can see the arrow moving? So can I get a thumbs up on that? I know Julius can. He gave me a thumbs up, but on the screen, I want to make sure everybody can see that. So as I'm here, I'm going to keep sweeping distal into that quadratus right there, that pronator quadratus, looking at that nerve right there, and it's going to start sneaking through that superficialis and coming up on top. Okay, so let me show everybody now that median nerve, hopefully everybody can see right here, is right in this area here. Now, on the screen, you can see I'm just at that volar wrist crease, that proximal wrist crease right here. Once I'm right in here, we're looking for this region right here. If you get lost, backtrack yourself and bring it back proximal. Now you can see it right in the middle of the screen again, right in here. As I go distal, watch as it rises up. Couple things that you're going to note while looking at this is, number one, in this region here, it's a rounded nerve. It's hyperechoic, and it has that nice honeycomb appearance. Now, what happens is as it passes and goes superficial to the superficialis, and it goes through this region here, you'll notice a couple things. Number one, it is not as hyperechoic. Okay, so it's this one right in here. And instead of being circular, it's more ovoid. And the reason for that is because it's under pressure. Now, when it's in the more proximal region through here, it's between two muscles. Okay, so now we're looking at a differentiation of the physics here. Okay, because it's nestled between two structures that have more fluid in them compared to the nerve, what you're going to see is it's hyperechoic. As it gets distal, and you see it up in this region here, and I just want to make sure everybody understands where it is. Right in here, it's more oval and it's more hypoechoic, okay? And that's because it's not shrouded by two water-filled spaces, or at least more water-filled spaces in muscle, okay? So as we look into this, so I want everybody to look at this, at the hand here, our big landmarks at this level, at that proximal crease, is going to be the scaphoid and the pisiform. Okay, so if you're going to be taking the RMSK exam, this may be on there. So they might have questions similar to what landmarks, and if you can isolate those landmarks, it becomes much easier to locate the median nerve. All right, so let's get our bearings here. We're back at that proximal row. You can see the median nerve right in here. As I sweep a little bit more distal, you'll see a bony outline. Let me get that lit up for you right here. There's a bony outline right here. That's on the radial side, so that's going to be the scaphoid. As we sweep ulnar, you're going to see another bony landmark. That's the pisiform, okay? Right in the middle of that, let me get a clean picture of the two together. And sometimes you may not get the both in together, but right in here, you can see scaphoid, pisiform, this little triangular space right in here, that's that ulnar artery and nerve right in here. That's what they call the tunnel of Guillain. Guillain? Colin, how do you say it?
I pronounce it Guillin's canal.
Guillain, okay. So that's going to be this little area right in here. This is that volar retinacular space. Okay, so this is that carpal space right in here. So you can see this band that comes up and across. It almost makes this little rainbow right in here. Now, why is that important? Well, that is going to keep the flexor digitorum at bay, and you can see the median nerve sitting right in the middle here, okay? Now, as I'm scanning here, just be sure you understand where you're at. You're at that proximal crease. You can see that scaphoid on the left of the screen and the pisiform on the right of the screen. Now, also from this point of view, it's really important to notice a couple other structures while you're trying to identify the median nerve. Number one, you have this circular space right in here, flexor carpi radialis. Now, why is that important? Well, it becomes important because it's not within this row right here. So see this halo, this space that comes up and over, this rainbow. This is the retinaculum. This is what the carpal tunnel is. And so as this space cuts off down in through here, that flexor carpi radialis is actually not within that carpal row. Okay, it's not within that carpal tunnel. However, what is, and then again, this is important, is down in here, you have the flexor pollicis. I'm going to have you move your thumb for me, sir. Let me get a better, cleaner picture. There we go. So you can see flexor pollicis right here. That's within the carpal row. Flexor carpi radialis is outside. Here is that flexor retinaculum, and you can see the nerve sitting right below. Now, this is another tool. This is like a little clinical pearl. Is while you're here, if they start getting symptoms, some people call that a sono-Tinel's sign. It's just doing a Tinel's and seeing if it's symptomatic. But now you're just doing the ultrasound probe. And how's that view right there? Can you see it okay? All right. All right, so let's review one more time. So as we're at 4 centimeters from that proximal crease of the wrist, you can see the median nerve right here. As we come up and go distal, 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 you'll see that pronator quadratus sticking down at the bottom here. That's your identifiers when that median nerve is going to start going superficial. Watch that median nerve go just between the superficialis and sneak on top. Here's a good area right at this first proximal row to get a measurement, okay? And so if you're going to get a measurement at this level, Colin, back me up. What are the numbers for a median nerve to consider pathologic versus normal?
You're talking about the level of the pisiform and the scaphoid?
Correct. So here's my scaphoid. Here's my pisiform. And right in here, let me hit freeze so everybody can see right where I'm at. Right in here is my median nerve. Okay, so here's that carpal row, or that carpal retinaculum. So there's that flexor retinaculum right through here. Here's the superficialis and profundus. Here's the median nerve right here. It's this cylindrical, almost ovoid shape right here. You can see the tunnel of Guillain right through here. If I were to measure this, what circumference or what measurements am I looking for? Yeah.
So there's a range of measurements. There's a study by Zisweiler that talks about the spectrum of disease and how to classify it at this level. And so usually between 8 and 12 millimeters squared is somewhere in like the quote normal range. Between 12 and 15 millimeters squared, you're talking about borderline. And then anything 15 millimeters squared or more in that area is considered like a slam dunk. Generally, that's been correlated with the EMG studies. So is that kind of answer your question where you're going?
That's exactly where I was going.
Okay.
So with that in mind, I want everybody to see that I measured this out, and it's at 0.09 centimeters squared, which is well within normal parameters. Now, Elias, do you have carpal tunnel syndrome? Do you have symptoms into this hand?
Fingertips.
The fingertips go. So when I'm doing this right here, does that send any kind of weirdness down in there? Oh, okay.
So there's always outliers too. So there are cases where people don't fit into nice, neat little boxes. So this is used as a guide. You're also going to be looking for dynamic flattening, any bulging of the carpal ligament, swelling of the nerve. There's certain features that go along with it that don't just isolate to the actual circumference. Okay, so it's your role as a clinician to decide how you're going to apply the ultrasound to the clinical case.
Let's take a closer look at this one more time. So everybody can look at the screen here. Let me get a picture of that scaphoid so everybody sees it. Okay, now we're going to go ahead and measure this one more time. You always want to be, what my grandpa always said, measure twice, cut once. Don't worry, we're not cutting, Julius. Thank God. Oops. Let's get out of this. Quick look at this. There's the scaphoid right here. There's my median nerve right here. Are you having symptoms with this right now? No, not right now. Okay. All right. So everybody can see here the area. That's Stefan. All right. Well, that's not letting me use my cursor right now. Let's try that again. Well, without messing with it too much. We know that is within normal measurements at that level. Okay, so once again, everybody, on the left of the screen is the scaphoid. That's flexor carpi radialis, right up on the top. Flexor pollicis, just adjacent, right down in here. Here's the flexor retinaculum, right through here, and the median nerve, right in here. And this is where you'd want to measure it. Okay, now one view is no view. Obviously, we say that with a lot of things, right? And so what we want to do is we want to see how that median nerve looks in long axis as well. Because what will happen is as it goes through the retinacular space, through the tunnel, what will end up happening is it'll compress at that level. Well, prior to the compression, it'll have a widened area, and then distal to the compressed area will have a widened area. They call that an hourglass presentation because it's going to look like wide, narrow, wide, and it'll look like an hourglass. So what I recommend is when you're in here and you can locate that scaphoid and that pisiform, once you've located that median nerve right in the middle there, what I recommend from this point is going 90 degrees. So I'm going to let everybody see where my where my probe is. I'm going to work 90 degrees. I can see that median nerve right in the middle of the screen. Right through here. Right there. Okay. I'm going to put a little extension on your wrist. Okay. Now, if everybody can see what we have right there is we have the median nerve sitting on top. We have the retinaculum sitting superficial to that. And then we have the flexors deep to that. Now, what we're looking for is within this region, just proximal to the retinaculum and just distal to the retinaculum. So right in this space will be narrowed and flattened, and proximal and distal to it will actually be widened. So that's going to be your hourglass presentation. And if you're not sure, like if that's the right place, what you can always do is once I locate this one more time, right in here, what I can have my patient do is, can you wiggle your fingers for me slowly? Wiggle those fingers. What you'll notice is as I'm doing this, the flexors will be moving. There we go. You'll see the flexors moving deep, but that nerve sitting above it does not glide with it. So let me try that one more time right there. You don't see that nerve glide. Anything to add to that, Colin?
Yeah, the only thing I would add is sometimes you're looking for quality gliding. So as Ryan was talking about, as you're flexing those fingers, a couple of the characteristics that come in with people with carpal tunnel-like symptoms are, sometimes the nerve will actually kind of, it'll seem like it's moving retrograde as you're flexing the tendon. So it's like moving the opposite direction. And so that's a secondary sign of some kind of adherence from either from the flexors or more often than not on the superficial side, like the ligament or the retinaculum.
Right. One thing I want to point out is when we get back to the screen over here, is one good way to get a better view is to have that wrist in a little bit of extension. So sometimes what we'll do is we'll just either take a gel bottle or a small bolster, and you can just put it under the wrist here, and you can get a little bit more extension out of that. And so let's see if we can get a better view of that median nerve. There we go. So there's this median nerve nestled right on top right here. And you can see the pisiform to the right. And of course, the scaphoid on the left. So hopefully that's clear. It's not clear as mud. Hopefully that makes sense to everybody to how they can scan it, what the parameters for normal versus abnormal, some of your structures that you're going to find in here. So if I were a betting person and I knew I was going to go take the RMSK, I would look at this exact image right here that has the pisiform and the scaphoid, and I would memorize that. Just saying. Just saying. Okay. From that, like I usually from this point, I like going into the dorsal wrist, because one thing that we tend to see a lot of is first dorsal compartment tenosynovitis. Well, what the heck is that, right? Well, we're going to go over the 6 dorsal compartments, but in the first dorsal compartment, we have APL and EPD. Well, what does that stand for? APL, abductor pollicis longus. Okay, so that's your abductor. And you have extensor pollicis brevis, EPB. Now, what tends to happen is there's a couple anatomic variations as that first dorsal compartment crosses over that CMC or over that distal radius. What you might see is them sharing a sheath, or they might have 2 completely separate spaces. Now, knowing that, typically the APL or the abductor pollicis longus is about twice the size of the EPL or EPB. And what you're looking for is thickening of that space. And there's no specific cutoff to how thick it is. This is going to be one of those things that you're going to have to get really good at. And the other thing is if they have a left hand that's symptomatic and a right hand that's asymptomatic, it's always worth looking at both sides, especially if you're unsure. Now, what does tenosynovitis mean? Well, that means as the tendon is coming through, there's a sheath around it. If that sheath becomes irritated and filled with synovium, it'll create fluid around the tendon, and that is tenosynovitis. Okay, so that's the synovium being inflamed around it within that tendinous sheath. Now, before we go too far, same thing applies that we talked about with the volar wrist in the carpal tunnel. Is one good way to get a better image is while you have the patient in this position here. Is this okay? Okay. You could take a bolster or like a gel bottle or anything here, and you could just prop that hand up a little bit into flexion. So now you're going to get into wrist flexion, and you can see the wrist right through here. What we're feeling for, and I think this is what they call the lighthouse of the wrist, right? Colin, you've heard that before, the lighthouse of the wrist. Mm-hmm. Lighthouse of the wrist is on the distal radius. It's called Lister's tubercle. And if you followed us on social media, if you've ever looked at any one of our LinkedIn posts, I go over this a lot because I think it's super important to understand this landmark. So if you go to the distal radius and you find this little bump right here, that's going to be Lister's tubercle. That's going to be our lighthouse of the wrist. Now I'm going to start this in short axis. And what I'm looking for is I'm looking for that protuberance that kind of sticks up. Now for him, he's got an interesting, now you've broken this wrist. He's broken this wrist twice. FYI, he's played professional football. What positions?
Receiver and defensive back.
Receiver. So you need your hands. So they got injured. Completely injured. So we may find some abnormalities in here. So his Lister's tubercle is this bump right in here. Get a better view of it. His happens to be slightly, I don't want to say irregular, but I want to say that his is slightly changed to what I would typically see. Now, what we're looking at is this space right in here. That's Lister's tubercle. How about your other wrist real quick? Is that one messed up too? We'll find out. You broke this one too. And well, I'll be honest, this one looks a lot easier to see. Okay, so that's going to what your typical Lister's tubercle is going to look just like that. So let's go to this one though, because here's the thing is people are going to walk into your clinic. They're not going to be normal. That's why they're getting skinny. And so we're going to do the best that we can looking at this space right in here. So if anybody can see my scan, you can see that I'm on that dorsal side. I'm on the distal radius until I get this little bump right on top. Now that bump represents a space that separates dorsal compartment 2 and 3. Okay, so 2 and 3 are going to be the ones that are separated here. All right, so once I've located Lister's tubercle, I know I can go to that radial side. We're going to sneak past this one right here, okay? And we're going to go right over until we see this space right here. What we have is this larger APL and EPV. So he does not have synovium around it. It does not look overly thickened. You can have them move their thumb, or you can passively move their thumb to see these move. And out of the 6 dorsal compartments, I typically look at number 1 and number 6 in 2 planes, unless I see something abnormal in the other 4. Now, as I'm going through here, again, locating Lister's tubercle, passing over dorsal compartment 2, and sliding over the wrist a little bit until you see this space right here. Once again, he has a sheath between the two, so it's really easy to recognize EPL and APV. Yes,
real quick, do you want to take a second and describe, so these are tenosynovial sheaths, and we have some people who are brand new to ultrasound. You want to describe the appearance of like what a normal one is, what to look, because like if it's a sheath, should we be able to see the sheath?
Not always. Now, here's the thing, is when you look at this, and let me get a good clean picture of the two together. Here we go. So when looking at this, and hopefully everybody can see this, if I zoom it in anymore, we'll lose something here, but here's APL right here. Now you see this thin filament that's right over the top through here? That's going to be part of the sheath. Usually you don't see it until it's distended. Okay, so normally this is what it should look like right through here. Abnormally, or in tenosynovitis, this little layer right here will be filled with fluid. And what it's going to look like is if you've ever seen a target sign, or a bullseye sign where you have a target in the middle and a line around it, that's what you'll see for tenosynovitis. Also, here's the thing is the difference between tendonitis or tendinopathy and tenosynovitis. Well, one involves the tendon proper, one involves the synovial sheath around it. Now, here's the question is how often do they go hand in hand? Hand in hand. I guess that's funny, huh? But how often do they coincide with each other? Quite a bit, actually. So if you have tenosynovitis, a lot of the times you also have a tendinopathy involved with it. Can you have tenosynovitis independently? Absolutely. Can you have tendinopathy without tenosynovitis? Absolutely. But what I tend to see in clinic is they tend to go together. Colin, would you agree with that?
Absolutely.
Absolutely. That's nice. So we agree sometimes. All right. So from this point, what I like to do, again, 1 in 6 compartments. So between compartment 1 and compartment 6, I like to see them in 2 planes. All right. So can everybody remember what, and you can write it in the comments if you want, what is the lighthouse of the dorsal wrist? Okay. So I have it right here. I won't give any spoilers away. Hopefully everybody was listening. Are you doing the polls? Oh, he's doing the polls. Man, this guy's on top of it. He said I shouldn't use the word Colin Rigney and engineering in the same sentence. But I mean, what he's doing right now is actually really difficult work. It's actually pretty difficult. Like there's a lot of things going on the back end here.
So yeah, just so like there's things that like both of us do really well, and there's other things that like I've said we don't do well, but things we just don't like doing, right? And so for Ryan, it's calendars. For me, it's like anything that has to do with controlling a keyboard and, you know, this camera, anyways. But hey, we're here. I'm learning new skills, just like some of you guys are learning how to learn from Ryan here tonight. We're all in. Okay, back to the show.
Back to the show, he says. I'm glad everybody's here listening to us. If you're having a good time, if you're learning a little something, throw a thumbs up and obviously throw a clap. Don't give the clap. Throw the clap up for Colin for working his hardest on the back end of this. All right. So once again, and if everybody wrote in there, it is Lister's tubercle. So I see that camera's following me right now. I'm not liking that. That's AI for you, everybody. All right. So as we rotate, we get Lister's tubercle. ECRB, ECRL, don't worry about that one right now. As we roll over, we see these two right here. So these are good right here. This is a good image of APL and EPB. From this perspective, I like rotating it 90 degrees, okay? And what I'm looking for is this tendinous space right over the top. Now, Colin, remind us, what should a tendon look like in long axis? What are the sonographic appearance of that tendon?
Sonographic appearance of the tendon in long axis, we are looking for parallel linear fibers. This should be bright and should pop right out of the screen on you.
So as we come across his wrist here, he does have a little thickening, but what we're looking for is the long axis. So what we have, so this is distal to the left, proximal to the left, distal to the right. And what we're looking for is this fibrous space right through here. Now you can see this dives down a little bit because there's a little slack in it. To get rid of the slack, what can you do? Is you can put that thumb down, right? So you can push that thumb down and let's see if I can get a better picture. You can push that thumb down and it'll take some of that slack out. Another thing you can do is a little bit of ulnar deviation. So if you do ulnar deviation, let's go back to that image. There we go. Do a little ulnar deviation and it takes the slack right out of that tendon.
Let me make a quick point because Ryan does something very crucial there. And this is also something that doesn't just apply to the wrist. But if you want to see any structure in the body with ultrasound with more clarity and its optimal echo texture, you should think about putting it on a tension. So whether it's a stress or some kind of tension. So the clinician in you is going to have to work that through.
Absolutely. Absolutely. Yeah. I mean, anybody can get scans, but the best of us understand how the human body works, the kinematics, the mobility, the mechanics of things. And if you understand how to put something on stretch or how to take it off stretch or how to compress a joint or how to put something in open pack versus closed pack. Now, these are terminologies that we use in physical therapy, but you need to understand there's going to be certain things that you need to understand to change the outcomes of that image. Colin, yes.
Question
Question.
from Katie. Thank you. Is that fluid normal? So maybe go back to the view you were looking at. And I saw the same thing too. So you want to
We're
point
looking
that
at
out?
arterial.
Yeah.
So let me clear that up. So Katie is looking at this fluid just deep to the structure. Well, guess what? When in doubt and you see fluid, what do? We put color Doppler on and we see if it's pulsatile. So what we actually have is that's not a synovial fluid. That's not a joint fluid or any of any sort. It's not edema. What it is that's vascular. So you can see right in here, that's a vascular structure. So good question. I mean, that's a great question because here's the thing is just deep to that area, you have the CMC, all right? That carpal metacarpal joint, that saddle joint, and it is notorious for osteoarthritic conditions, which means it's also notorious for synovitis, okay? And so just where that arterial space is you could have synovial proliferation or an accumulation of synovium right there. So it's always good to check right there, make sure that that's not vascular. Good question. All right. So that's first dorsal compartment, APL, EPB. As we're going through, we've got 5 more to do. Now, with the next 5, I'll breeze through a little bit of them. I don't want to oversell them because a lot of the times these are not implicated. What you're usually looking for is 1 and 6. That's going to be a question at the end of this, is which dorsal compartments are highly implicated for pathology. 1 and 6. Yes, Colin.
I was going to say, I'll throw a wild card in there too.
Oh, wild. Okay. We'll talk about the wild
I'll
card.
get there.
All right. And you'll hear me say this a lot. When in doubt, use more gel. Okay. Especially with superficial structures like this. Floating the probe, actually, this is actually a good point, is floating the probe means putting excessive gel or additional gel on the probe. So that way, as you're scanning through, you're not actually getting contact of skin on the probe. You're getting gel in the probe and you're floating that. Okay. So as we return, I'm floating the probe. I'm finding Lister's tubercle. Now, remembering, Lister separates 2 and 3. So right in here, we have ECRL and ECRB. Okay, so that's important, mainly so you understand your reference point from APL and EPB, from the first dorsal compartment. But right in here, where do we tend to see pathology of ECRB and ECRL? It's not typically distal. Usually we think of tennis elbow or lateral epicondylgia, and that's going to be more on the elbow proximal side. So we don't tend to see as much here. Lister's tubercle, I slide slightly radial, and I can see ECRL and ECRB. To me, they always look like eyes. I got this one and I got this one right here. Now, one thing to note while we're here is sometimes you will get something called you'll get like a compression through here. You'll get like almost like a compartment space. What we can have here is an area where 2 tendons cross over each other. And you can get synovial buildup right in there. All right. Let's look at compartment number 3. Now his 3, looking at his Lister's tubercle, his 3 kind of sits in a groove, which is not typical. It's right in this area right here. So
Did you fracture that bone, the radius?
Yeah, fractured.
So yeah, so just quick ortho pearl, right? Distal radius fractures, we should always be concerned about the integrity of the extensor pollicis longus, because the way it has to travel through, it comes straight down and takes a straight hard left to get out there right over Lister's. So it's a critical zone to be mindful of. So if any of you are managing those types of patients in the post-op care, you should always be testing the integrity of their ability to activate the EPL.
Absolutely. Okay, so coming back to Lister's tubercle, and you can see he fractured his wrist. So in this little space right in here, go ahead and move your thumb for me. I don't know if anybody can see that definitively, but this little space is moving right here. That's EPL, okay? So that's the 3rd dorsal compartment, okay? From the 3rd dorsal compartment, as we slide slightly ulnar, we're going to see this larger group of tendons right through here. Now, what that is that's extensor digitorum, what they call the proper extensor digitorum. And within that bundle, they also have one called the indices, your trigger finger, right? Now, if you look at this, you can clearly see there's a small area right in here. That's indices right in here. And this is going to be digits 3 and 4 right in here. The whole grouping of this is dorsal compartment number 4, also known as ED. Okay, so extensor digitorum. You can just call that extensor digitorum. Now, sometimes you can get synovial proliferation depending on like rheumatic type of disorders. This is an area that we've seen some swelling and some synovium proliferation in there. So we've seen, what you're going to look for is within this sheath right in here, you'll see fluid. Okay, Lister's tubercle moving over. Now you can see, go ahead and wiggle your fingers for me. And you can see extensor digitorum and indices. Can you move just your index finger, just the pointer finger? That's this guy right in here. Now, I think this is a good clinical pearl right in here. If you can get the distal ulna, this is this rounded shape right here, and you can see the flattened radius. So this is the ulna right here. This is the radius right here. This is going to be, I won't quiz you. I'll go ahead and give you the answer. But they call this the gateway to the wrist, more for interventional people, for people doing injections, things like that. But what we have is this little V shape right in here. Now, before we get to dorsal compartment 5, I want to just note that its location sits above this joint. This is one of those fun ones to say. This is the drudge, the distal radial ulnar joint, okay? This joint right here is utilized a lot for interventionalists for getting into that carpal row. So just letting everybody know, this is drudge right in here. And sitting above it is going to be extensor digiti minimi. And you'll hear me say this a lot. In some literature, you'll hear it called quintus or 5. So that's going to be your digiti minimi. Okay. So I'm going to see if we can isolate that pinky. Not always the easiest for people, especially since Julius here broke his pinky. You dislocated this pinky. What didn't she do?
That's a good question.
That's a good question. So right in here is digiti minimi. And as we roll across, and everybody sees that ulna right through here. So there's drudge right here. As we roll across, we're going to get this last little, let me float that probe. We get one last, and yours clicks, by the way.
Mm-hmm.
I mean, you have a significant click. Right over that ridge of the ulna is this little valley right in here, and that's where ECU, extensor carpi ulnaris, sits. Now, this one is controlling that volar space right here, so going into that ulnar deviation, and you can see it right in here. This is another common area for tenosynovitis. Once you want to see that in short axis, and then rotate that to long axis. Now, one thing that's really helpful is when you're looking at this one, you can go into radial deviation if they have it. Okay, so if they have radial deviation, or at least a fair amount of radial deviation, you can put them into this position here, and you're looking for ECU right in here. And you can see there's a little slack on it. I'm going to try and take some of that slack out. Right in here. And his is pretty thick right here. There's his right there. Now, Colin, what sits deep to that ECU? What is that funky space deep to there?
Right. You want to freeze that real quick? Actually, get the nice one with the triangle.
Yeah, hold on. Let me do that with my foot. Can everybody see that? Yeah, let me do that with my foot. That's one thing that.
So as you're going, hold on. I'll talk it through. Okay, so as you're looking at Ryan, get his picture underneath there. We see the extensor carpi ulnaris in long axis. I want you to fix your eyes to the structure that's closest to the ulna. So where the ulna drops off and the first thing it falls into, that's your triangular fibrocartilage complex, and this is the meniscus of the wrist. So ultrasound can be a good tool to evaluate just a general health sense of it. Not super sensitive in detecting like the type or the extent of tears, but it can give you a very good idea if you need to order an MRI or anything like that, if there's enough suspicion on this to warrant. And so the sweet part about it is you can do some dynamic testing here. We can do some compression, some grinding, and see if how stable that structure is. So back to you, Ryan.
Yeah. So looking at this picture here, what we have is the distal ulna, and we have the ECU sitting on top. Down in this area here, we have a complex. So we have the TFC, or the triangular fibrocartilage, sitting on top. And then you have this little buckle that sits around it. And that makes the complex. That's the homolog, the meniscus homolog. Now, if Julius had more radial deviation, what I could do is I could gap that a little more, and you would see the radius down at the bottom. Now, where my arrow is going, you would see the radius come in here. Now, he has limited radial deviation, so I can't open that space up enough without causing him pain. But when you get that radius to come in right down in this area, what will happen is it'll reflect that meniscus and that TFC a little bit brighter. Yes, Colin.
Luli, I had one question. TFCC, some information, please. I'm just going to give you just a super brief break. It's a fibrocartilage, so it's like a spacer. It's a bushing for the joint that keeps a space and keeps the joint of the ulna and the radius and the wrist bones to align and function as geometrically optimal as possible. Okay, so it's like a spacer to keep all of those tight little bones where they're supposed to be and prevent instability. Hope that's helpful.
Thank you, Professor Rigney. So Colin is right. It is a spacer because we know that the distal ulna is not as long as the distal radius. And so there's a bigger gap in there. So you need a cushion in there. So, all right. Now, something I want to go over while I'm here is, do we all remember this bony landmark? Okay. Hopefully everybody knows that is Lister's tubercle. Guess what? From this point, we can find the scapholunate joint and ligament. Okay. So if you can put Lister's tubercle right in the middle of your screen and just go distal, that's going to disappear. You're going to get a little gap. Then all of a sudden, you're going to get this V shape right in here. Okay. What this V shape represents, obviously to the radial side. So to the radial side is going to be the scaphoid. To the ulnar side is going to be the lunate. Right in between here, you see this ligamentous complex, this fibrocartilage down through here, and then you can see this band that connects bone to bone. We know bone to bone is going to be ligamentous. This is your ligamentous space called the scapholunate ligament. Okay, why is that important? Well, because this gets disrupted a lot. Now, are they always repaired? Well, it depends. It depends on the severity of the injury. It depends on the function of the wrist. It depends on a lot of other factors. But what you're looking for is in this area here, you're looking for disruption of this space. Well, statically, these can fool you. Okay, statically, these can look healthy and they can look normal. Here's the thing that I've always told our practitioners in clinic and all our residents is when you find the scapholunate ligament, okay, so we see it right here, there's a couple ways that you can gap this. Number one is as you're stabilized here, you can move them into radial and ulnar deviation. So this is radial deviation. This is ulnar deviation. I'm blocking the bone. So I'm over here on the pisiform and I'm blocking that distal ulna and I'm opening this space up. It is not gapping. Okay. The other thing you can do, and this is what they used to do with x-rays, is you can have your patient slowly make a fist. Squeeze that out. And for him, he does have, go ahead and hold that fist tight right there. So for him, he does have a little fibrocartilage disruption in here, but that band is intact. I would imagine with the type of sports that he's played, this has been disrupted at some point, especially as a receiver. Anytime that you're hitting the ground with your foosh or any other kind of disruption, you're going to see these quite a bit, but you need to check them dynamically. So that's the scapholunate. Everybody remember, find Lister's or the closest thing to Lister's, in Julius's case, and go distal until you see this V. That's your scapholunate joint and ligament complex. Okay. Now, because of time, I just want to see how everybody's doing. Everybody doing good so far?
Thumbs up.
Thumbs up. That's great because the next one is going to be the carpal metacarpal. So, Colin, what comprises the carpal metacarpal? What bones are we looking for?
At the first intersection?
Yeah, for the carpal.
Yes, first carpal metacarpal. So we're looking at the trapezium. It's at the distal carpal roll on the radial side. It's going to interface with the proximal metacarpal. And so Ryan's going to demonstrate that here.
Yeah. So if you can find your radius, pretty easy. What's the next thing that's right off the radius? Should be the scaphoid, right?
Mhm.
Call that Mr. Peanut sometimes. And after that, what's the next bone?
The trapezium,
Okay. So what does the trapezium connect to?
the hand bone.
The hand bone. All right. And so your CMC, carpal metacarpal joint, is right here. Okay. And what we're looking for, and again, I'm probably hiding it from view. Let's see if I can do a better job of this.
Use your right hand, maybe.
So if I do my right hand, you can see that joint space right in here. And what you want to do to test it is you can go ahead and flex that thumb a little bit, see how it gaps, see if there's any disruption in there. The next joint in line is what?
Missed your question.
Oh, what's the next joint? What's the next distal joint?
Distal joint,
Yeah.
metacarpal phalangeal.
So we know the metacarpal phalangeal joint, really easy to palpate. Just put it right on that thumb. Did you mess your thumb up too? Mm-hmm. Of course you did. You have some osteophytic ridges of that.
You want to point that out, Rupert?
Yeah. You tore that guy. Okay, hold on 1 second. We get a better image.
You point out what make you came to that realization.
All right. So what I was doing is I was testing it dynamically, and what I'm looking for is, so this is the metacarpal phalanx. So this is your metacarpal, this is your phalanx. I'm looking at this joint space right here. As I sweep and scan, I'll have you note that this ridge comes up and over a little higher than typical. Okay, we call that an osteophytic ridge. Another thing that we're looking at is the joint space in here. Okay, so as I'm through here, I want everybody to kind of locate, see that little step right in that joint on both the metacarpal and the phalanx. And you can see some fluid accumulating near that joint space as I flex it right in there. See that kind of bunch up a little bit? So that would be something probably consistent with early onset type of DJD. Obviously, always confirm those type of things with plain film. All right, so that's going to be CMC. And if anybody's wondering how to inject these, what you want to do is you want to, first and foremost, is you always want to locate where's your arterial spaces, okay? So for him, he's got this massive artery on that radial side right here, okay? So we want to avoid that and go long access. And from here, since it's on that radial side or closer to the volar side, point of entry is you'd put that joint space right in the middle of your screen. And if you can see what I'm doing here is needle entry would be what they call out of plane. Okay, so in plane is when the needle goes in line with the probe. Out of plane is in this direction here. And guess what? We're going to be doing an injection course or an injection webinar here pretty soon with a guest speaker, not telling you who. All right, and then we're going to go over these type of techniques. But anyway, that's called a step-down technique, out of plane, long access to the CMC joint. Okay, yes, Colin, anything to add to that?
Yeah, and you should always have multiple ways to access it, because with people who have pretty significant arthritis, you're gonna find that the space is extremely narrow and it's not one size fits all setup. So sometimes you can actually access it better just straight out of plane. But if you can't do that, sometimes you have to take an oblique approach and come over the joint and go in plane with it. So that comes with experience, but again, the variability with these arthropathies that can happen at the wrist, in the hand, are unique to pretty much anywhere else in the body, with some exceptions maybe in the foot.
Nice. As we move forward, the big thing that we're going to talk about is pulleys. Okay, so one of our residents is actually a rock climber aficionado. He treats rock climbers quite a bit. So what do we know about the pulley systems in rock climbing? We know with that gripping, you can have disruption of the A2 pulley. The A1 pulley is usually what they call trigger finger, okay? And what we'll do is we'll kind of walk you through what that means, what the anatomy is, and how that relates to MSK ultrasound. So the pulley systems, so if I have my flexors that come down the finger, go ahead and flex your finger, it creates this moment arm right here. What happens is we have these little rings that go around the finger called pulleys. The odd pulleys are on the joints. The even pulleys are on the bone shaft. Okay, that's important to note because if you're looking for more of a trigger, that's typically when that pulley gets congealed, it gets thickened, it gets, tendinopic, it just gets adhesed to that flexor tendon. And what will happen is in full flexion, it'll catch on that pulley or that ring. And as you go out through there, you won't be able to open your finger. That's usually the telltale sign of a trigger finger, A1 or A3 pulley. Now, what can happen, especially with like rock climbers, is that pulley that's on the shaft here, if that pulls off and tears, what will happen is that tendon no longer stays close to the bone and it pulls outward. And what you'll see is the tendon going from that interphalangeal space down to that first or that second metacarpal space, carpal MCP joint, and you'll see it bowstring up. So it'll look like almost like a bow and arrow. You'll see that bow up. So to locate A1 pulley, which is the trigger, I usually just have that bolster and I'll use my fingers here to put them into extension. I'm going to go ahead and go short access first. And what I'm looking for there we go. So I'm on the metacarpal space right now. So I'm not on the phalanx yet. So I'm on the metacarpal space. And what I'm looking for is this image right here. What you see is this is the metacarpal right here in short access. This is the flexor tendon in short access right in here. And what I'm looking for is I'm looking for thickening, disruption, and that A1 pulley. Again, if this is going to be short access of the tendon, it's technically going to be long access of the pulley. And so what that looks like is going around this space right here. It's this darkened area right here. Now, here's the thing is you can see the retinaculum, you can see that pulley go around even in normal anatomy, but it's really thin. And sometimes people say it's actually easier to see in long access. And I'll show you that here in a second. But what will happen is this small space over the top will get thickened, irregular. And this is where a lot of people do like almost like a hydrodissection through this area, split or cleave that pulley system from the tendon so it frees it up from that adherence. Again, look forward to our injection series. Okay, so that's short access. So one view is no view in this scenario, right? So we see there's that pulley coming up over the top. Now, see this little bony apparatus right here? Don't get freaked out. Some people have an anatomic variation of a sesamoid that goes through in here, so don't worry about that too much, unless it's another fracture. No, he didn't fracture that one. Okay. And so what we're going to do is we're going to go into long axis again. I'm going to put a little extension on that finger. I'm going to rotate 90 degrees. There's the metacarpal. There's that sesamoid right there. There we go. And right over top, let me see if I can clean that up a little bit. There we go. Right over top, what we see is this secondary line right over here. See, here's the metacarpal. Here's this right in here. That's going to keep beeping. So we'll just hit off. Yeah, that's my timer. It's telling me that we're running short on time, everybody. Hope everybody's enjoying this. We're just going to finish up with this last one. And then I'll have Colin come do a Stenner's for those. That'll be kind of a bonus is doing a Stenner's lesion. So once again, metacarpal. There's the tendon over top. I can flex that tendon real quick. And that's the sheath sitting right on top. So that is your A1 pulley. And like I said, what you'll see is thickening irregularity just superficial to the tendon. I'm going to have Colin hop in. He's going to do a Stenner's. I think this will be bonus, and that gives me a little time to catch up with some people and answer some questions if anybody has questions. Now's the time. Everybody, ask your questions. This is super, super important. Colin's going to sneak in here. He's going to teach what I consider. I'm going to do this without knocking wires over. All right. So,
Okay, so this would be a challenge. Let me know how this looks on your end.
looks good to me.
Okay, so the setup for this is generally, because it's such a dynamic exam, and really this isn't part of the standard exam, you're going to deploy this window when you have a clinical suspicion for an injury, or if you get an order to scan for this particular injury. So generally, I'm not going here unless I'm hunting for something. So the ulnar collateral ligament of the thumb is associated with a couple injuries, also known as gamekeeper's thumb. There's a condition called a Stenner lesion, which can also accompany this injury. Okay, but they have different meanings. So let's get into it. So often it's a two-handed job. So meaning I'm going to need to use my other hand for support. So hopefully you guys can see this. I'm going to, as best I can, support. So it's very key when you're using your offhand. You don't want to put them in too much valgus and just crank their thumb. So I'm going to use the thenar eminence here and buttress against the joint. So when I do stretch it, they're supported. And so if in the case of an injury there.
And right now your lead hand is covering try with your other hand if you can.
Okay. Here, let me take a different window. So this is a little bit better. Let me know.
We can see it just fine now.
How this is.
Yeah, the audience can see.
Okay,
that.
Thanks, guys. Thank you for your feedback. So, it wouldn't surprise me. I know my other hand's in the way, but let me get to it. So, have you had an injury here before? Quite possible. Yeah. Okay.
Just okay that down.
Yeah. So, let's just cover a couple things, and I'm going to do my best to give you a nice, crisp, clear picture. So we're going to start by orienting our bony landmarks. On the right-hand side, this is the proximal phalanx. On the left-hand side, this is your metacarpal. And the tissue that connects the two bones, this infolding, this is the ligament proper. And then off out here, because left is proximal, this is the adductor pollicis. So this is the muscle that brings the thumb closer to the hand. Well, over the top of that tendon, or that muscle, as it forms a tendon, comes across. That's what this bright streak is here, and it loops all the way around. So it functions like a buttress over the top of that ligament, adding reinforcement. This is an inherently flexible joint. And so the anatomy is designed to have a little bit of give and take for movements, because we do so much with our thumb, we don't realize until it's injured. So now we're going to get this view back, and we'll show you how we look at this dynamically. Let's see if I can do this without getting in my own way. Probably a little bit better view here. So two crisp, clear, bony landmarks. The ligament is the piece of tissue that's connecting the two bones, and over the top is our bright white tendon. And so the first things we look to clear, is there a Stenner lesion? So most Stenner lesions are when there's been an abrupt or forceful injury and a gap to this joint, and this tendon snaps a piece of bone with it. Most often it occurs at the proximal phalanx. However, we did have a recent case that came off the metacarpal, and it can happen. It's usually more of an outlier, but again, be on the lookout for it. So I look to clear that first, and then after this, we're going to do our gapping. So you're going to see, this is the challenge. I know my hand's in the way. So what I'm doing is I'm keeping the probe steady with my left, and my offhand, I'm just doing a little valgus stress. And you see everything's grossly intact. Nothing is pulling away and moving paradoxically. So as I'm pushing, or as I'm applying the stress, you see the bone and the tissues moving. You see the bone and the tissue moving in sync with the stress maneuver. So I hope that covered the content with respect to the ulnar flato ligament of the thumb.
That was perfect.
Yeah. So
Yeah, I think that's just one of those things that might come offhand, might come into the clinic. We did have a question is do you ever use water as a medium for the ultrasound? Yeah, absolutely. I just taught this on one of our LinkedIn posts. I showed how to do a water bath. I think it's actually really good for small joint spaces such as hand and wrist and foot and ankle. Now the issue I have with that is getting the water bath, the mess that it could make. But if you're having a hard time with gel or a standoff pad or anything like that, water is a great medium. You always want to check your manufacturer's guidelines on if you can submerge the probe. As far as I know, all the ones that we have in our clinics, they are able to do water bath submersion. And I think it has very clear resolution when you use water as a medium.
Mm-hmm.
So, and then you can also float that probe, a couple centimeters away from the actual tissue and still get a good resonance.
Mm-hmm.
So, all right, everybody, that was the hand and wrist. I'm going to pull up a chair. Julius, you are complete, my friend.
I know we had one question by Ryan asking about, and Ryan, if you want to pull up, maybe you can also be involved in this one.
Yeah, I'll come up.
Asking about when you eject you need a towel, huh?
Yeah.
Here, you can use one of these.
Worst out the ligament. Well, first and foremost, as we're going to do a little chatting here, this is a little Q&A. I'm going to come up and over and chat with Colin. We want to say thank you, everybody, for joining us. Is a hockey stick probe better? Lulia, let's talk about that. So hopefully everybody can see me come into the plane here. Here's the thing with hockey sticks is, can you do everything with a linear probe? I remember being taught by our mentor, Wayne Smith, is you should be able to do 95+% of all your scans with a linear probe. Somebody asked what size this was. This is an L15-4, which is about 15 megahertz. So it's a higher megahertz probe. And if you listened into our physics, you would know that the higher the frequency, the better the resolution. Can you use a hockey stick? That was one of the questions. Is absolutely. Is it necessary? No. I think you can do almost everything with this probe. You get into sticky situations with obesity, high body habitus, deeper structures like the hip. Those kind of things you're going to have to move into like a curvilinear. But hand, wrist, foot, ankle, those things you can get away with a linear. Now, if you have the availability of a hockey stick, absolutely. Especially when you're talking about injections, because it's a lower footprint and it's easier to maneuver around.
Yeah, and also some of the resolutions on the hockey sticks, we're getting up to 20, 22, 24 megahertz. So it's ultra resolute. Is very common to see in like a rheumatology office where they're doing a lot of procedures. That's the preferred probe as they're seeing a lot of those conditions in the hand and the foot. But like Ryan said, if you're using MSK sonography to look at everything in the body, not just isolated to the hand and the wrist, it's best practice to learn and use and apply the linear probe to as much as you can, because it's going to make you a better sonographer in general. And once you get to that point, you built the foundation with the linear probe, then you can transition more to a hockey stick probe. Yeah. In my opinion. Now, if it's like a combined diagnostician and interventionalist, I think that's a different conversation. But from a strictly diagnostic perspective, it's best to learn the foundation with the linear.
100%. So I'm going to be going back through all the questions that we had, and I'm going to be answering all of you personally. This was a fantastic time for us. If you could throw a thumbs up for all the people on the back end that helped us out. This is our team. We have Michael, we have Torero. These two have worked endlessly to make these happen. All the promotions that you see online, everything that you see, all the really cool animations, everything is done by our team. So I just want to give them a big hands up or a thumbs up. So I just want everybody to recognize how awesome they are. This wouldn't happen without them. And I want to also thank Colin for getting on the back end and trying his best to work on the camera. I'm going to go back and watch the video to see how that went.
And my engineering hat.
My engineering hat. And so thank you, everybody. We're going to be signing off. Send all your questions. If this is something that you guys and you gals out there are interested in more of, we're going to be doing these again more and more every month. And a little sneak peek is at the end of the year, we're going to be putting on an entire summit of all this information that we did here. We're going to be putting on continuing education. So you're going to get credit. So now sitting in here, just listening to us banter, what about listening to us banter and getting continuing education for it? I think that's probably one of the best things that we can offer for the community. So if you're all interested in that, throw a thumbs up, something that we're working tirelessly to make sure that it happens for all of you. I'm going to be walking back to the computer answering questions. Colin, did you have anything else to say before we sign off?
No, this is great, guys. I really appreciate all of you. Thank you for spending the time with us, choosing to spend your time with us. Tell your friends about what we do, and certainly we're going to be doing more of this. We very much look forward to it.
And thank you, everybody that's writing us these amazing comments. Wow. You guys are really hitting us up with some amazing comments here. Thank you. Getting a bunch of clapping and thumbs up. So everybody, thanks for sticking around. All of you from around the world, we're signing off. We look forward to seeing you next month.
Good night, everyone.